Hi, today we are going to discuss about rhesus isoimmunization. Blood group of an individual is identified by antigen on RBC surface. They are ABO antigen and rhesus antigen. The expression of rhesus antigen has autosomal dominant inheritance. In rhesus isoimmunization, when rhesus negative mother conceived with rhesus positive fetus, the fetal RBC start to show rhesus antigen from 30 days of age. In that case, there is no positive rhesus antigen in mother's circulation as she is rhesus negative, but there is rhesus antigen in fetus circulation as he or she is rhesus positive. If an event of fetal-maternal hemorrhage is occurred where the fetal RBC exposed to maternal circulation, it results in immune response in mother to produce antibodies against the fetal RBCs. Mother initially produces anti-D IgM antibodies. The IgM antibodies are pentamers, so they can't cross the placenta. In first pregnancy, the amount of immune reaction is small and also IgM antibodies can't cross placenta. So the first baby is not affected. But in subsequent pregnancies, if resensitization is occurred, mother produces anti-D IgG antibodies. These antibodies can cross placenta and destroy fetal red blood cells. It results in hemolytic disease of fetus. It can cause severe fetal anemia, result in hydrops fetalis. Then we consider about fetal-maternal hemorrhages. In first trimester, miscarriage, ectopic pregnancy, termination of pregnancy can get, and in second trimester, amniocentesis, abdominal trauma, antepartum hemorrhage are possible examples for fetal-maternal hemorrhage. In third trimester, antepartum hemorrhage, external cephalic version, intrauterine death, delivery are possible examples. In rhesus negative mother, the first antibody screening test is done at booking visit. If the test is negative, the subsequent tests are done at 28th week and 34th week. If the mother is not sensitized, routine antenatal anti-D prophylaxis is given to cover silent fetal-maternal hemorrhage after 28 weeks. There are two regimes. They are 2 doses of 500 international unit anti-D Ig at 28 and 34 weeks of gestation can be given, or single dose of 1500 international unit at 28 weeks of gestation can be given. If an potential fetal-maternal hemorrhage is occurred, like these examples, anti-D immunoglobulin should be given within 72 hours of potential fetal-maternal hemorrhage event. The dose is 250 international unit for event before 20 weeks. If that event is occurred after 20 weeks, 500 international unit should be given. And also, if that event occurred after 20 weeks, quantification of fetal-maternal hemorrhage should be assessed by Klehover test to see whether additional dose is required. After the birth of the baby, cord blood is tested for blood group and rhesus factor, hemoglobin level, serum bilirubin level, direct comb test, reticulocyte count. These tests are done to assess the baby is affected. If the baby is rhesus positive, 500 international unit of rhogam is given within 72 hours and 3-hour test should be done to see whether additional dose is needed. If the 3-hour test is not available, 1500 international unit of rhogam is given to the baby. After the birth of baby, the cord bud should be taken and also rhogam should be given. Then we discuss about management of rhesus sensitized mother. If the genetic testing of the fetus confirm that the baby is rhesus negative, no further assessment is required. Otherwise, severity of maternal sensitization should be assessed every 2 weeks until delivery. Quantification of maternal anti-D antibodies level can be done with titer or by international unit. If titer is rising more than 1 to 16 or level is more than 4 international unit, fetus should be closely monitored in a fetal medicine specialist unit to assess hemolysis in the fetus. For assessment of baby, serial amniocentesis for amniotic fluid bilirubin test can be done. It is an invasive method, and also assessment of baby can be done non-invasive method like ultrasound. In that ultrasound, fetal middle cerebral artery peak systolic velocity is used as screening tool to detect fetal anemia. This test should be done weekly. And also, fetus is monitored for signs of hydrospitalis and fetal anemia. The signs are polyhydramnios, skin edema, cardiomegaly, ascites, pleural or pericardial effusion, bowel dilation, and increased placental thickness. If fetal anemia is suspected, we have to diagnose the condition. The fetal blood sampling by cold synthesis is the only definitive method of diagnosis fetal anemia by direct measurement of fetal hemoglobin to perform intrauterine blood transfusion. If we have to do intrauterine blood transfusion, the transfused blood should be rhesus negative, cross-match with maternal sample. It should be cytomegalovirus negative and densely packed and irradiated and leukoreduced, and this should be less than 72 hours old. The optimal time of delivery is determined by considering period of amenorrhea, severity of fetal disease, the need of intrauterine transfusion, and fetal lung maturity. And this should be decided by multidisciplinary team. At birth, the neonatologist should be available and blood should be ready to treatment, and cord blood is taken for investigation. After the birth, the mother should be encouraged to feed the baby regularly to ensure that baby does not become dehydrated, as the dehydration can increase severity of jaundice. Thank you.